So my name's Jen. I'm from the committee from NSTS and also in my FY2 year, working in Yorkshire at the moment. So you may recognise me and this slide from one of the previous bonus webinars, which was kind of preparing yourself for your first surgical FY1 on call. And we just thought it might be a good opportunity to look into a bit more about the multidisciplinary team and who is there to help you. So this is a slide that one of the last bonus webinar ended on, but we just thought it was useful to have an opportunity to listen to more kind of specialty doctors and trainees, other people in the MDT, basically for a bit more advice and to make you feel less alone when you start a job. I think it's really important to say that the best thing about working in a hospital is that you have a big team around you. And when you start your job, especially as an FY1, but even starting a new job whenever you work as a doctor, you may have very little practical experience in that role, but the most useful thing to remember and be reassured by is that you have a team of experienced and qualified healthcare professionals around you, and they're an absolute wealth of knowledge, so they can always be there to support you. So I'll quickly whiz through this list and then we'll talk about what else we're going to talk about in today's webinar. So as we previously mentioned, surgical nurses are absolutely fantastic to get on the right side of. Most of them can help with skills like catheters, especially when you're looking at wounds or dressings for the first time, looking at drains contents, then these are the people to go to if you're not quite sure what you're looking at, because they have a fantastic range of experience. I'd signpost you back to have a look at our post-operative complications, to listen from a med-reg who gave that talk, because he had really good advice about what's useful to know, especially when you're bleeping for help if you can't get help from your own seniors. Important to recognise the clinical support that you might have as an F1 or an F2 when you're starting at hospitals. I'm going to talk a little bit more today about some advice from pharmacists and think what might be useful in the future. We've got a specialty radiology trainee who's here to give us some more advice about scans and imaging, and also people like the physios and the therapy teams, and other more specialty nurses like in palliative care and Macmillan nurses. We've got a few tips from there as well. Just to say as well, the most important times I think when an MDT comes together, especially in relation to your roles, is often in cancer patients and often in discharges. So it's really useful to be aware of all of these people, basically to help give patients the best care possible. So what we're going to do today, so the objective of this talk is basically to gain a wider understanding of who makes up the MDT around you, what you can learn from them and how they can help guide you as a foundation doctor. We've got more detailed and specialty advice from a radiology trainee who I'll introduce you to shortly, and he's available here so that we can ask any questions that we might have. I'm then going to just give some top tips from some other healthcare professionals that I spoke to while preparing for this talk. So specifically the ones that I found were quite useful, that came up as recurring themes, were the ward pharmacist, and also who was on the surgical ward, and also an upper GI Macmillan clinical nurse specialist who deals a lot with the cancer care that you can sometimes see, and she was really useful, and also be keen to teach in the future if that's something that would be helpful for you listeners. So I think today, hopefully, as we go through, obviously this is the first one of the kind of these talks, and we can recognise any gaps and understandings that future sessions might help with as well. So now I'm just going to introduce you to Edem. So Edem's a Radiology ST3. He's working in Leeds and West Yorkshire at the moment, and he studied at Leeds Medical School as well. He's planning on a career in non-vascular intervention with a particular interest in GE. He might be able to tell you a bit more about that. He really enjoys teaching, and basically he's here to share some advice based on his personal experiences about how to best utilise radiology appropriately, request the right images for patients, and also give us some specific tips about requesting, I think, as well, so that we can defy the stereotypes that this meme shows, and make sure that we give patients really good clinical care and use radiology appropriately. So over to you, Edem, if that's okay. I'll stop sharing my slides now.
So yeah, thanks for the introduction, Jen, and thanks for inviting me to talk to you guys. So my name's Edem, I'm an ST3 working in the Leeds area at the moment. So I've been doing a few years radiology, so at night sometimes will be in charge of a major trauma centre, and obviously it means that you end up speaking to a lot of people about requests. And there are some good requests that you get, some bad requests that you get, some in between, but hopefully after this conversation it will make you feel kind of more confident when you have to have those discussions. So got a couple of objectives. So just basically I'm going to talk about the different modalities that we have in radiology and the relative merits of those. Talk about some of the common surgical indications which may require someone to have surgery, and an understanding of why you might be requesting a certain test. Then after we go through that, I'm going to talk about, structuring a good radiology request, and hopefully throughout all this, it will increase your confidence in having conversation with radiology, and I'll be able to convince you that not all radiologists are mean, as some of the stereotypes would have you believe. So there are quite a few misconceptions, I think, flying around about radiology, some possibly well-earned, others not so. So I think the common one is that radiologists can be really difficult, they're unhelpful, and they can be quite mean. They don't like accepting scans, particularly from juniors, and they'll only take them from the seniors, and that you're going to have to be creative to get your scans accepted. And so I'm going to tell you a story about when I first started working, which kind of reinforces this, but actually hopefully by the end you'll see that it actually goes to show that radiologists aren't quite like that. So I remember I started F1 in York, and on the first day, one of the consultants said, "Oh, Edem, can you go and discuss this scan with radiology?" So I trot down to radiology, and in York you have to go to speak to these radiologists face to face. And so I go in, I'm like, "Oh, hi, I'm Edem, I'm one of the new F1s. Can I discuss this scan? We've got this chap who's post-op. Can we have this CT?" And so they start looking at the request, and they're like, "Oh, okay, so what's the patient's white cell count?" I'm just like, "Oh, I'm not sure, sorry." They're like, "Oh, what operation did they have?" I was like, "Oh, God, I'm not entirely sure, sorry." They're like, "Well, what's the plan for this patient?" I was like, "Oh, God, I don't know." So then she looks at me and she goes, "This isn't going very well, is it?" And I was just like, "No, this isn't going well at all." But then she was like, "Look, I've read the request. I'm going to accept the scan, but as I'm sure you're aware, this isn't good enough. You need to know your patients much better, and you need to know what's going on if you're going to come down and discuss a scan." So I left tail between my legs, but obviously realizing that I couldn't just walk down and say, "Hey, can we have this scan?" So hopefully what I'll show you, the reality is that most radiologists want to help you. And when you're in a surgical specialty, most patients who come through are going to need some form of imaging. Everyone seems to get an abdominal x-ray. That's not always the answer, and CT is also not always the answer. The reality is that having incomplete or poor requests sometimes ends up with patients having the wrong test or having the right test, but at the wrong time. And being able to make the appropriate request at the right time will save you time. And if you can get the job done, then it makes your work easier and your bosses will probably be impressed. And just highlight the point that radiologists want to ensure that the right test is being done for the right reason at the right time. So I guess the question is, what makes requesting in surgery so difficult? And I guess it's because there's so many different pathologies. Within the abdomen, you could have stone disease, you can have infections, you can have vascular problems, you can have things like obstruction or perforation. Then we go in and operate, and after you operate, you can have complications related to that. You can have gynae things. So there's lots of different things going on in the abdomen, and it can't be that easy to tell. Sometimes you'll do a great history, do an examination, you're still none the wiser. And so this picture is your classic surgical sieve, showing you all the things that can go wrong. And as well as the surgical stuff, we've got the medical stuff. You can have a pneumonia that presents as abdo pain, or a heart attack that presents as abdominal pain. So we have all these things, and we have to try and narrow it down to figure out what's going on. And it gets even more complicated when it comes to radiology, because then you have options. Do you need an X-ray? Do you need an ultrasound? Do you need a CT? Do you need an MRI? And I think it's one of those things that in medical school, no one really teaches you how to go about requesting things or what the appropriate investigations are for certain things. So start with abdominal x-rays. And with abdominal x-rays, there are only 3 indications. The only time you actually need an abdominal x-ray is if the question is obstruction, perforation, or foreign body. And so we've got 3 examples here. The first one on the left is a good going obstruction. Then the one in the middle is a perforation. You can see that because if you can see here, they've got free air under their diaphragm, which is a sign of perforation. Obviously, you can see these radiopaque foreign bodies. I think that there's a misconception that every surgical patient needs an erect chest and abdominal film, because there's the belief that that's what the registrar and the consultant are going to want. But actually, that's not the case a lot of the time. If it's not one of these three reasons, then a lot of the time you can skip doing an abdominal X-ray. So the next thing I'm going to talk about is ultrasound. So with all modalities, there are pros and cons. So of all the radiology modalities, ultrasound is one of the cheapest. It's a dynamic exam, and what I mean by that is that you're creating the pictures in real time. That's useful in particular for things like gallstones, where you can see something in the gallbladder, you get the patient's change position, and you see if the gallstones move. And if they do, that increases your predictive value that yes, this is gallstones, they might have cholecystitis. No radiation. We don't mind giving people radiation, but we know that it can cause cancer and increase the risk. So anything that doesn't involve radiation gets a thumbs up from radiology. And it's really, really good for looking at the genitourinary system, and that's in males and females. Negative sides of it is that it's operator dependent. So if you've got someone inexperienced, then sometimes they might not be able to pick up the pathologies that someone more experienced would. Patient factors, because you're popping a probe on the abdomen. If the patient's in a lot of pain, they might not tolerate it particularly well. Or the other side of the coin is that patients who are on the larger side, you might not get the penetration you need, so you can't get good enough picture to give you to help with your diagnosis. Mostly patients need to be fasted, which isn't often the case in an acute setting. And if the worry is something to do with bowel, then ultrasound's not really going to help you. So back to this, and I'm just going to talk about the things that ultrasound is particularly good for in acute patients. So cholecystitis, ultrasound is fantastic in. You can use it for hepatitis, but that's much more biochemical diagnosis. Pyelonephritis, stone disease, it's great. Male and female GU. If you're doing work with kids, ultrasound is primarily the investigation used. Normally people might have some plain films, but then for most abdominal pathologies, kids will have an ultrasound first. And I've included AAA follow-up in this. You wouldn't want to diagnose an acute AAA rupture on an ultrasound, but if you were following one up, then ultrasound would be the modality of choice. So what would I want to know as a radiologist if someone's requesting ultrasound? And I'm going to highlight the top point again and again throughout the talk, and it's that the written request that you make should be able to justify your scan without discussion. So that's not saying that if the request is urgent, you shouldn't call and discuss it, but it's saying that that should be able to stand alone. The reason I say that is because a lot of the time, the person who you'll be speaking to about the scan is not necessarily the person who'll be reporting the scan. And the written request is what's pulled through to our reporting system. So sometimes someone will have written a request which seems a bit sketchy, you're not really sure what's going on, and then you call them and they have this great discussion telling you exactly what's going on, all the bloods, exactly where the pain is, and you think, okay, this scan is completely justifiable, it makes perfect sense, but then the person who's reporting it isn't privy to that information. Whilst if your written request contains all that information, then it makes it easier for the person who's looking at it initially. If you haven't had chance to call, they can look at it. Yep, perfect. This scan needs to be done. I'll go ahead and vet it. So things we want to know, the basic things: your patient demographics, their relevant past medical history. If they've had an operation, particularly with things like ultrasound. The last thing you want is to be spending 5 minutes looking for someone's gallbladder for them to then say, "Oh, by the way, doctor, I've had my gallbladder taken out." We want to know the chronicity, where it is the pain on the right, is the pain on the left, makes difference in when you're interrogating those organs. Then the relevant symptoms and clinical findings. If you're worried about infection, we want to know about their blood markers. And it's really important to include a suspected diagnosis. Of course, that's not always going to be right, but it gives us a good place to look and make sure that that area will be interrogated more extensively to look for the subtle signs of infection. So I'll now move on to CT, which is called the donut of truth. You have a question: does my patient have appendicitis? You put them through the CT scanner, and usually you'll get an answer. So it's the workhorse for radiology. Lots of patients end up having CTs, and it's great because it identifies pathology. You might think your patient's got X, and it can answer that yes. It'll help you find the complications, and then sometimes it'll help you find the incidentals, which can be kind of a good thing or a bad thing. but it's not so simple as just requesting a CT. So in regards to as June doctor, yes, it's as simple as requesting a CT, but from the radiology side, then we're deciding, does your patient need a non-contrast scan? Do we want to give them contrast? If we do, is it going to be arterial? Is it going to be portal venous? Is it going to be triple phase delayed? It's not important for you to know all the different phases, but important to know why, So with the clinical information you provide, we're going to be making that decision. So if you're saying, this patient is post-op and we're worried that they might have a leak of their anastomosis, then you're like, okay, well, this patient's going to need rectal contrast. If the question is, oh, we think this patient might have complicated stone disease, then you then, okay, this can be a non-contrast. So that's why your clinical question, the clinical context is important to help guide us to make sure that we're doing the right scan for your patient. So the pros of CT is that it's quick. Most patients are in and out of the CT department within kind of 5 to 10 minutes. It's not operator dependent. By that, I mean, so long as the patient can lie on the couch still for the duration of the scan, then anyone can have a CT. The negatives are the ionizing radiation. We don't like doing unnecessary scans, particularly if people end up having lots and lots of scans. It's not great for looking at the pelvic organs. And if you do the wrong protocol, you might find that you don't get an answer to your question, then you have to come back and do another scan. And then incidental findings can be obviously a good thing, but they can be a bad thing if it's something that you're not expecting and you don't really know what you're going to do with. So these are things that CT is quite good for. So, we've got your bleeding things, your rupture AAA, your dissection, that's great for that. Ischemia of the bowel or viscera, your infections, your appendicitis, your diverticulitis, and then it's great for looking to identify a site of obstruction or a site of perforation. So whilst I said that we can use a plain film for those, they can show you that someone's had a perforation or that they are obstructed. But then your CT is what you're going to use to try and identify the sites of those things. So what do I want to know? So as I said, I'm going to highlight this point that the written request should be able to justify the scan without discussion. So we want, the usual stuff, your demographics, your chronicity, your laterality, your findings, your bloods. The most important thing for CT to remember is to include the patient's renal function. If we're going to be giving them contrast, it can knock off their renal function. So it's really important for us to know that. And it's kind of a pet peeve. So if it's not included on the request, then it is possible, obviously, to find it through the system. But when you're trying to manage a busy department and you've got people calling you kind of every couple of minutes, those extra minutes can be frustrating, and especially when it's something that is usually known to the team before they request the scan. And then we're going to go on to MRI. I mean, this is going to be a very short section. MRI, we very rarely use it acutely. Patients tend to have long protocols, and so they have to be barely stable to have one. The only real indications that they're used for acutely from a surgical perspective is for MRCP when we think someone's got stone disease but we can't see it, or for small bowel MR for inflammatory bowel disease patients. But those don't tend to be on admission. Those tend to be kind of part of the course, and they tend to be more senior conversations. So I've just included them here and I've included where it shows the pancreatitis, because it's normally used for is there pancreatitis secondary to stones? And then I've included the inflammatory bowel diseases at the bottom. What would we want to know for an MR? It's the same thing. Your written request should be able to justify your scan without discussion. Once again, though, if it is urgent, it's important that you do call. But then the same thing, your demographics, your chronicity, laterality, all those things. And once again, because sometimes with contrast to the MR, it's important to know the EGFR as well. And once again, your suspected diagnosis or your clinical question, that's really important to include in all of your requests. So if we go back to choosing the right modality, we're going to use an abdominal film for if we're worried about obstruction, perforation, or foreign bodies. Ultrasound is good for things like cholecystitis or other stone disease, pyelonephritis, male and female genitourinary stuff, and if it's a child, ultrasound is likely to be our first port of call. And then CT is used for most other things. We've got our vascular things, all the other types of infection, obstruction, perforation. I've put pancreatitis complications there because, as you know, pancreatitis should be a a diagnosis based on the patient's clinical examination and their findings of raised amylase, yes, you can see pancreatitis on a CT, but it doesn't usually change the management unless we're worried about complications. And then obviously post-op complications, CT is the best modality for that. So we're going to kind of move now talking to radiology as part of the NBT, and I'm trying to do this not as a rant, but trying to be kind of productive and help you and make the transition into working a bit easier. So I said radiology isn't a commodity, treat it as you would any other specialty. And I only say that because sometimes the quality of requests that you get to radiology are not the same that you would get to other specialties. So for example, if you were calling cardiology because you had a patient that you were worried was having a heart attack, you wouldn't call them and say, "Oh, hi, I've got a 75-year-old chap who's got chest pain. I think he's having a heart attack. Can you come and see them?" But sometimes that's quality of pain you get, you know, like we've got right iliac fossa pain, query cause, CT, please. So it's about realizing that, you know, we are your clinical colleagues, and that basically treat the specialty as you would others. Don't just presume that you can request a scan and it's going to happen, and that what you write is not important, because it is. So bringing on to the second point, that the image interpretation occurs in the context of what you say. So, you know, if you tell us that a patient's had a previous cancer and then you see lymph nodes which you think, oh, maybe they're borderline on size, the fact that you know they've got a previous cancer is going to make you more suspicious or not. And so it's not saying that people aren't going to look carefully at a scan if there's insufficient information, but the information he gives us kind of guides us, because what we're looking for is signs of pathology. You know, your appendix isn't screaming out, "I am infected." You're looking for the signs around it which suggest that infection. So I've put that we'll be using your request to prioritize urgency. So what we normally say is that if you've got a routine request, you can make a request, you don't necessarily need to call. And if it's urgent, you should call. But normally someone's looking at the CT list, and if, you know, they read a request and it says something like, you know, 32-year-old chap, sudden onset abdominal pain, left iliac fossa, bowels not opening, X-ray shows free subdiaphragmatic gas, query perforation, then someone's going to read that and be there like, yep, this is a scan that needs to be done urgently. We'll get the patient down right now. Bonuses is if it's included their white cell count and their EGFR, because then you don't even need to call them. You can just say, yep, speech radiographers, get the patient down, and that'll be done. But obviously, if you call that information as well, that's useful. And the most important thing is to know the clinical question and how the scan's going to affect management. So sometimes the clinical question can be, we don't know what's going on, and to an extent, that is okay as well. But also knowing how the scan's going to affect management is really important in helping to prioritize not only urgency, but also seeing if that is the right scan to be able to guide you in the right direction. So the quality of your request matters. So I've got 4 examples here of requests that I've seen, and I mean, they're all scans that ended up happening, but as you can see, some of the requests are better than others. So if we start with the one on the top left, car hit curb, passenger, can we have a trauma of the seat, the chest, abdomen, and pelvis? You know, it doesn't really tell you anything. And I guess the assumption would be this patient probably isn't that unwell, but you just think, you know, they meet the criteria. However, it could be the fact that, you know, they've hit the curb at 60 miles an hour, all the airbags have gone, they were the passenger and they were thrown out of the vehicle. But with this, you get no idea of, you know, is this patient well? Are they unwell? Are we worried they've got significant injury, or are we not? Similar with the top right, had a fall, hit his head, query brain injury. You know, it could be that someone was sitting on their chair and just fell off and bumped their head on the wall, or it could be that, you know, they've fallen off a 10-foot wall. We have no idea. And then I've included one on the bottom left because, you know, also your request should make sense. So you read this one, 2 days of sudden onset pain, left upper quadrant, okay. Bowels open for 4 days, okay. Then we've got blood in the urine, a renal function which looks like it's going off, and then diverticulitis, and you kind of think, you know, it feels like it's leading you towards one thing and then goes to the other. So it just makes sure that your request makes sense. And then the one on the bottom right, which on one level looks like it's a really bad request, but I actually think it's quite a good request. Help, please. This is probably delirium, but it's way off baseline, hasn't improved over the last week, change in behavior, any bleed or mass. So the reason I like this request is because, you know, they've given you the patient's background. We know they've got autism. They think it's probably delirium, but they've got concerns. Have they got a bleed? Have they got a mass? You've got specific questions to ask From this, you can say, yes, doing a CT is the right modality to answer the clinical question that they've got. So just tips for working with radiology, but I think this is probably relevant to speaking with most specialists in the hospital. Be polite, introduce yourself. I've put it's a request, not an order. So this is more just a pet peeve of lots of radiologists. Lots of people say, hi, I've ordered a CT scan. And I know a lot of my colleagues will say, would you like some fries with that? It's just one of those things, again, it's to do with professional courtesy. You wouldn't call, I'll use cardiology again, to demand they come and see your patient, but you're calling them to have a discussion about coming to see your patient. It's the same with radiology. You're calling to say that, we want to do this scan. Is this appropriate? Can we get it done? Make sure you include any relevant past medical history. If there are unilateral symptoms, specify, it's on the left, it's on the right. Lots of times people will say that this isn't specific to CT, but you'll be reporting a chest x-ray and they'll say unilateral Krebs. And, a chest x-ray can hide lots. And if you know the symptoms are on the left and you see something which normally you'd dismiss, you'd think, okay, maybe that could be infection. I mean, it's neither here nor there, but if you specify the side, it can be really helpful. Include the relevant bloods, so that'll be white cell count and CRP if you're worried about infection, particularly if it's going to be a CT or an MR, include the EGFR. There are guidelines for CT heads, use them. It's one of those things where lots of people need CT heads, and it's very easy to justify them. There are CT head guidelines. If you can just say, like, I've got a patient, they're 65 on warfarin, they fall and hit their head. It's simple as that. Just look at the guidelines and it's very, very straightforward if your patient needs one or not. And then when you make the request, you can use the guidelines to basically formulate your request. Have a clinical question. If you don't know, ask. So the reason that can be important is the other week I had a request that had come through from a patient, and it said they knew they had surgical emphysema, but then they were querying if the patient had a pneumo mediastinum. So they'd had a chest x-ray that day, which I opened up, and I was like, well, I can see they've got pneumo mediastinum on this chest x-ray. So I ended up giving them a call, and I spoke to one of the juniors, and I was like, hi, just wondering if, you just want to know, is it a yes, no pneumo mediastinum, or was there something else you're trying to answer? Because, if the question is, do they have the pneumo mediastinum, then like, yes, they do. Do we still want the CT? They had a chat with their consultant, and the consultant was there like, oh, okay, I wasn't sure. If you're happy they've got one, then that's absolutely fine. So having a clinical question can save you, because, it can guide people to saying, this is a better modality, or saying, actually, you don't need this test because we've been able to answer it in this way. Acronyms are not always your friend. So when I've been reporting some MSK stuff from Bradford, there's one person who works in the A&E department who they always use an acronym when they're talking about fractures, and they'll say, fallen, hit right arm, deformity, query fracture, query STI. And it's a bit weird when you're thinking, like, why are they talking about STI with a fracture, until you realize they're talking about soft tissue injury. So, lots of specialties have lots of different acronyms, but they're not necessarily going to be, people in other specialties aren't going to know the common acronyms. So when you can, avoid using them. If it's urgent, call, and we are your colleagues. You can always call to ask for advice. It's acceptable to say, we've got a patient, I'm not sure what the right test for them is. Can you give me some advice? So just to summarize everything we've been through, the key point I want you to take back is that your written request should be able to justify your scan without need for discussion. That's not saying you don't need to discuss it, but the request should be able to stand by itself. Know your clinical question and how it's going to affect your management. The only times that you should be requesting an abdo x-ray is if the question is obstruction, perforation, or query for on body. Remember that ultrasound is good for stone disease, GU stuff, and for kids. And if you don't know, ask. And that can be your consultant or radiology. Just that if you don't know, ask. If you're asked to request a CT and you're not sure why, often it'll be a lot quicker for you to ask your consultant, oh, what's the clinical question, or what are we trying to find, than speaking to radiology, not really knowing what's going on, and then being sent back to speak to your consultant when you're reg again. So that's probably the most important thing. Well, the second most important thing is that if you don't know, ask. So when you go and have the conversation, you're well armed. Thank you very much. Are there any questions? And I've just included my email in the bottom there if anyone's got any question that you want to email me.
Hi, so a couple of questions that I can ask you, Edem, if that's okay. So we just had, this is also from last time as well, there was a question about vetting and when do scans need vetting? And I guess that's kind of what we were saying, also distinguishing between a radiographer and a radiologist. So where do the requests go, basically, and who?
Yeah. So it's a bit of a complex question, but I'll try and answer it in the simplest ways. So I think, so a lot of the x-rays are vetted by the radiographers. So we don't tend to be involved in a lot of that, but basically every scan that you do needs to have a justification for the exposure. So all CT requests will be vetted by a radiologist, all MRI requests will be vetted. So, and the way it works in Bradford is that there's someone who's on duty for radiology, and there'll be like a vetting list. So there'll be a list of all the scans that have been requested from the hospital, and you kind of work through them, and then you decide, okay, yep, this needs to be done urgently, or this is routine, this can be done when there's time. So essentially every scan needs to be vetted, but not every scan needs to be discussed, if that makes sense. So if, the question is, query cancer, or, it's a staging or something like that, then you don't necessarily need to call up, it will be picked up. But if, you've got a patient, they're like, we think they've we want to take them to theatre in 2 hours, then that is the kind of stuff that you do need to call. So every scan is going to be vetted, but depending on the urgency of intervention, that should guide whether you need to make a phone call or not.
That's really useful, thank you. Another question is, are there any calls that you would expect? Basically, are there any scans that juniors can't request? Is there ever a time where you would expect a more senior person and a foundation doctor to call the radiographer?
I think if you speak to different radiologists, you will get different answers, which isn't particularly helpful. From my perspective, if you know enough to be able to have the conversation, then I'm happy to talk to anyone. But obviously there are some times where it's very complicated, where it makes much more sense for the registrar. And like, it sounds really patronizing when you say it, but because sometimes there's someone calls me and asks me about something, and I'm like, oh, sorry, I don't know, you're going to need to speak to my consultant. So I think if you're happy to discuss it, I would be happy to discuss it with you. But I guess it's one of those things that if you know enough about the case and you're happy that you understand and you're able to explain why you want the scan, then personally, and I think most of my colleagues are the same. I know there's one consultant I know who works in, well, I won't say where they work, but they have this, they don't like talking to anyone who's not a reg or above. Personally, I think that it doesn't make sense, because it's not like suddenly you become a registrar and then you have this ability to talk to radiology and know all the right things to say. It's all a process, isn't it? From my experiences, the first time I went down to go to radiology, I had an absolute nightmare, and then you learn from it. I still remember the first time I worked a renal job after that. I remember going down to radiology, and I had a question, but then I'd learned all the bloods, I'd learned, all the investigations they'd had, blah, blah, what antibiotics they're on. I went down and I was like, oh, we've got a patient, they're this old, this is what's going on. We want to scan because we're wondering about this. This is our question. And they're like, yeah, okay, that's fine. I remember I was like, no. I was like, no, ask me some questions. Like, I was like, I've learned so much. So, it's all the process. So personally, I'm happy speaking to anyone, so long as you know your limitation. I think sometimes people feel like if you say, I need to speak to your reg, or you need to go back and speak to someone else, that you failed. But I don't think you need to see it as a fact that you failed. It's just the fact that sometimes you just don't have the answers that can make the scan justifiable.
Very useful, thank you. And then there was a question about radiology out of hours. So I think this is probably hospital and trust dependent, but from your experience, is there any advice about how things change out of hours, or requests, or what scans should and shouldn't be done out of hours?
So in terms of requesting, I'd say you can request anything at whatever time you want, but kind of out of hours, you should only really be calling about stuff that's going to change your patient's management overnight. So, you know, if you request, so I know lots of hospitals don't scan CTPAs overnight at all. So if you request, especially because most patients end up being on, you know, prophylactic treatment anyway, so you don't necessarily need to call to discuss that. But I guess things that sometimes frustrate people is when people get called about, you know, oh, I've had a look at this NG tube, is it in the right place at 3 a.m? Which obviously it's fantastic that you're looking at the X-ray, checking NG, but you know, whether that's reported at 3 a.m. or 8 a.m. isn't going to make a difference, because you know no one's going to start using that NG tube at 3 a.m. in the morning because someone said that yes, it's appropriately cited. So I think it's just having the cognizance to just be aware that, because obviously the person is on call and is possibly dealing with lots of other things, that if it's going to affect your patient's management overnight and it's important, then yes, of course, like make the call. But if it's just something where it's like, it would be useful to know. So sometimes I'd say, you know, if you've got a question about an NG, then by all means call at 7, 8 o'clock. Then if the person's not busy, then they'll always be happy, well, normally be happy to take a look. But it's a balance, I think, because it's not an out of hours reporting service. Obviously, if you've got a really tricky X-ray that you need someone to have a look at, then that's just the case, especially if it's going to affect the clinical decision making overnight. So don't be scared to call if you know it's important for the patient, but just have that thought, like, actually, does this question need to be answered now, or can it be answered in hours?
That's really useful, thank you. And thank you in general for your talk. I learned so much that I wish I'd known when I started my surgical job. But also, yeah, just really useful information about requesting and differentiating. So thank you for all of your knowledge. Very useful to know. Right, shall we switch our screens back?
Yeah.
Amazing, thanks very much. So just to finish off with this talk, obviously massive thanks to Edem and giving us some insight into radiology. So as we're trialling this lecture series and learning more from other MDT professionals, we had some input from a few other members of the MDT. So pharmacists got in touch, and one of the Macmillan clinical nurse specialists got in touch as well with some of their top tips. And we're also trialling this to see from other listeners, whether you're listening live or on YouTube in the future, as to who you might like to hear from using NSTS as a platform for other learning opportunities in the future. So I'm really briefly going to tell you James and Lisa's top tips that they gave me to share with you, and then going on from this on our feedback, if you've got anybody that you would like to hear from in the future, or hear a similar talk that Edem did from a specialist, then please let us know. So briefly, this is from James, one of the surgical pharmacists that I worked with. He just had some tips about what to let F1 students know, F1 doctors know coming in. So these are the things that he said. He just said, if you're feeling stuck or uncomfortable prescribing something, there are a number of options. Firstly, always remember that you can check the BNF and trust your guidelines as a first point of call, especially if it's your first time prescribing something, or when you're tired, when you're on call, it's always a good idea to check. If you're not sure and you can't find the answers, you can always speak to a pharmacist, and they'll always know what's in stock on the ward, and can sometimes help with dosing if you can't find what you're looking for in the guidelines. I think it's really important. One of his biggest tips was keeping the team involved, especially when you're planning on discharging patients, because you might need to know about what medications they need for discharge, what they already have at home, and what the system is for them going home as well. As an F1, you do a lot of discharge letters, and your pharmacy team can not only help you with admissions and knowing what medications they were on in the first place, but also it's really important to identify any changes that might have happened when they've been in hospital to notify their GP. So wanted to make that clear. He also mentioned gentamicin prescribing, and this was something that came up from the other first time being an F1 on call lecture that we did previously. So I'm really briefly going to go over the gentamicin guidelines, just so that they're here for you to refer back to in your own time. And it's mainly about handing over so that it's prescribed correctly. So bear with me if this is something that you're well informed of. But I've just put the guidelines from the Leeds Teaching Hospital here. So firstly, you assess if the patient is suitable. So why we all have talked about gentamicin and it can become a bit of a problem is because a lot of surgical inpatients are on what they call AMG, which is amoxicillin, metronidazole and gentamicin as an antibiotic combination. So if you're starting somebody on these antibiotics, these are the rough guidelines to see that they're suitable and they're not contraindicated. You should have some up-to-date usernees beforehand so you can work out the creatinine clearance. Then it's really important to diagnose the right amount. So this is where people get a bit confused, and it's also a really common OSCE question for prescribing. So useful to know about. I think the thing that always catches me off is you have to know their height as well to use this guide, and often people get weighed when they come into hospital but they don't have the height, so that's an important tip. How to give it, kindly the nurses majority of the time do that, so that's not such a problem for us to know. But the big key point here is that make sure there are levels taken between 6 and 14 hours after the first infusion. That might not be while you're still on shift, so it's really important to hand over just so that this time frame isn't missed. And obviously make sure that you document the time that you took it on the specimen. And then we just have this table here, which is the Hartford regime for gentamicin prescribing. And when you get that dose back, you can plot it so that you know how regularly they need their gentamicin. Obviously, the length that they might be on their antibiotics may vary depending on blood cultures or depending on your consultant's plan. But this was just something that was flagged up from last time that people are a bit confused about. But obviously, always check your trust guidelines, because these guidelines can probably vary trust to trust. So I hope that's helpful as a whistle-stop tour through gentamicin. And if speaking to a pharmacist or a microbiologist might be something that's useful, please put it in the feedback too. So just to finish off, as I mentioned before, one of the Macmillan clinical nurse specialists for upper GI cancer on the surgical wards reached out to us when they found out that we were doing this talk, and said that she would also be really keen to come and teach if that would be useful. So I'm briefly going to talk a bit about what they do, because I think, again, it was a service that I didn't know existed until I started work in the same way. So the clinical nurse specialists are a team of key workers and key contact for patients. They manage patients from diagnosis to their discharge, or sometimes up until their death, and help coordinate their care entirely. They can get dietitians involved, especially for upper GI, and they work both with the hospital team and in the community team. They're fantastic, giving advice to both patients, their relatives, and also the team looking after them. So as F1s and F2s, they can provide an absolute wealth of knowledge. Something that I learned that they do is a holistic needs assessment as well. So they look at their physical, their emotional, their personal, social, and increase their information. The main thing that Lisa wanted me to reiterate, especially if you're going onto the wards or starting a surgical job, is that especially in the time of COVID, the most important thing that she thinks is to remember is about communication, especially if this is a first cancer diagnosis for patients. They may not have their relatives with them. There may be communication breakdowns because of lack of continuity or information, especially in COVID times. So she said, sometimes as a foundation doctor, you can be the first ones on the surgical wards to be aware of a potential new diagnosis, and getting the Macmillan team in early, the clinical nurse specialists that are there in pretty much every hospital, can help you with that communication, especially if it's a conversation that you don't feel comfortable yet to have. You can get specialists in to help you with that. Again, she just wanted to mention that some of these vague symptoms may crop up in your patients, things like fatigue, jaundice, confusion, dysphagia, and breathlessness. And I think she mentioned that these are the 5 most common vague symptoms that sometimes crop up and they can easily be dismissed or be put down to other things. But they're important to remember that they could be because of an underlying cancer or a progression in cancer and may warrant further tests and investigations. Again, something that if you're not sure how to manage these, the Macmillan Clinical Nurse Specialists can get involved. You might want to do bloods for fatigue, for things like drop in haemoglobin, jaundice again, LFTs, or arrange further imaging. Things like confusion, you want to check calcium levels for hypercalcemia, and then dysphagia for progression, you may want to get further advice to how you manage that. And finally, breathlessness, it might be something like ruling out a pleural effusion, and so you want to make sure that they're not overloaded, and also for a PE as well. So if you've got any concerns with symptom management or palliation or having end-of-life discussions, it's really important to get the whole MDT involved, to seek support if you don't feel comfortable, and if your consultant or registrars are busy, and this is another team basically that are available, and can help with discharge planning as well and getting patients funding. So that's just a really brief kind of some top tips, some insight from some of the other members of the MDT that wanted to say and reach out just for a bit of advice. But if there's anything further that you would find useful from these talks, please let us know, get in touch. Again, massive thank you to Edem for his radiological input and teaching, and please use this QR code to fill out for our feedback. If there's any other questions, I will try and I think that's all okay, but I'll leave this QR code on for a little while, just so that you can use it to fill out your feedback. This lecture will also be recorded and available on YouTube for you to look back on as and when. Thank you very much.